Hello, thank you for joining us for the Systems for Action Research in Progress webinar. My name is Chris Lytle. I am Deputy Director at Systems for Action, and I'll be moderating this discussion. Systems for Action is a signature research program of the Robert Wood Johnson Foundation. Our studies create an evidence base for the connecting, alignment, and integration of public health, social services, and medical systems, with a goal of advancing health equity and improving population health. We offer this webinar as an opportunity for our grantee community to share innovative work at various stages of their studies. So without further ado, let's get into our agenda for today. Next slide, please. Thank you. So today we'll hear from Dr. William Riley and Detective Sabrina Taylor, and they'll be discussing multi-sector service delivery integration for behavioral health disorders and first responders, after which they'll answer questions from the audience. So be sure to enter any questions or observations into the Q&A box on the bottom of your screen. And we'll be able to answer those questions at that point. Next slide, please. Dr. William Riley is professor for the science of healthcare delivery in the College of Health Solutions at Arizona State University. You can read more about his background. We'll be sharing these slides with the audience afterwards, and it'll also be available on our website. Detective Sabrina Taylor will be providing some, she'll be commentating afterwards. She's been a police officer for 17 years, has served 5 years on the Los Angeles Police Department and 12 years with the Phoenix Police Department, and we really look forward to listening to what she has to share. So I'll go ahead and pass this along to Dr. Riley.
Chris, thank you very much. This is Bill Riley, and I am delighted to be here today with my colleague, Detective Sabrina Taylor from the Phoenix Police Department. And I'm waiting to get control, but in any event, our team has been conducting novel research on multi-sector alignment for 4 years now. And we selected behavioral health disorders because they are a very prevalent condition in society, yet an ideal sector to explore and test the Robert Wood Johnson Foundation action framework for increasing equity and improving the culture of health in our nation. And the reason that behavioral health disorders are such an important area of study is because the care fragmentation for BHDs really is a striking example of the conflicting financing mechanisms, conflicting policies, and an institutional bias in our healthcare system. And it touches on so many other sectors that we will talk about today. And the second reason is because the care for individuals with BHDs in this country has profound inequity, significant fragmentation, wasteful duplication, and a severe lack of coordination. And again, that's we believe that that's in part due to the multi-sector nature of treating persons with behavioral health disorders, as well as the institutional bias that, that accompanies that. Next slide, please. Thank you. So as going forward, can I click that? Oh, I see. Okay. All right. So we have a number of, as I mentioned, behavioral health disorders touches a number of sectors. And in the 4 years that we've been involved as a collaborating research center with the Systems for Action program, we have enjoyed and benefited tremendously from amazing community support. So the, oops. My apology, I'm still not able. Is it possible to go back to the previous slide, please? Previous slide. There we go. Thank you. No, there we go. So you can see that in the health and health-related sector, the payers are very involved, the state Medicaid program, the MCOs, Mercy Care, and so forth. We've worked extensively with crisis line and referral services. It's called the Crisis Response Network, and with many of the community referral providers for mobile teams and behavioral health and substance use treatment. And then, of course, the hospital EDs are really important in one respect, that an area that all of the stakeholders agree is that the emergency department, as well as the public safety system, are the defaults for the lack of care coordination that we have with persons with behavioral health disorders. And likewise, what you'll hear a lot about today is the public safety, the Phoenix Police Department, the Phoenix Fire Department, the Sheriff's Department, Correctional Health, Adult Probation, the county court system, as well as the local government, the mayor's office, the health department, and so forth. Next slide, please. We developed a conceptual model in conjunction with our stakeholders, and we've been operationalizing the Systems for Action framework. And the model has the following relationships. So as we worked with our stakeholders, we eventually defined the alignment problems, that's the first column, as the issues that are caused by fragmented, uncoordinated, or conflicting approaches in the multi-sector systems. The alignment mechanisms we are defining as a multi-sector consensus regarding both a solution and an implementation of a solution to resolve or to address the alignment problems. And then finally, the goal attainment is the systems level outcomes achieved as a result of the alignment mechanisms. And as with the alignment mechanisms, the goal attainment, we are identifying metrics that would be indicators of goal attainment. So next slide, please. Onto the public safety system. So in the city of Phoenix in 2017, there was a total of about 2.3 million calls to the 911 system. And of those, about 91% or 2.1 million calls were to the police department, and about 9% or about 590 a day were to the fire department. So again, about 590 a day for the fire department and about 5,900 a day to the police department. Next slide, please. So we focused on the 911 system, again, as a result of the guidance from our advisory committees, because the 911 system is a central crossroads for the multi-sector fragmentation in behavioral health. We focused on this because a substantial portion of the almost 2.4 million calls annually to the 911 dispatch center for both the fire department and the police department are behavioral health related. And it was really the police department and the fire department, again, who are on the front line of dealing with these behavioral health treatment system failures. And then along with the ED, those three sectors, police, fire, and the emergency department, are really the defaults for the lack of care coordination for these patients. And we found a very strong stakeholder consensus that the current multi-sector system is very poorly aligned to serve these patients appropriately, that they are not getting, but they are receiving very poor care coordination. And that results in an inefficient use of the very limited public safety resources. And in a sense, it's a goal displacement for both the police department and the fire department because of the amount of time and resources that is required to serve these high-risk individuals. Next slide, please. We adopted a model, it's called the Sequential Intercept model, that was developed about 20 years ago to help inform the community-based responses to the involvement of people with mental and substance use disorders that confront or interface with the criminal justice system. And the model identifies 5 intercepts. If you look from left to right, I don't think my mouse works, but Intercept 0, Intercept 1, Intercept 2, Intercept 3, thank you, Intercept 4, and Intercept 5. And in each of, so that's a process from the time that a person with mental health or substance use disorder encounters the criminal justice system. And this model identifies each intercept where there are opportunities to divert the individual away from the criminal justice system and into a more appropriate care services. So our project has been focusing on the first 2 intercepts, Intercept 0, which is community services, and then Intercept 1, which is law enforcement. And we have modified this model to also include the EMS system because of the substantial overlap that I had mentioned earlier. So next slide, please. So in the intercept model, the sequential intercept model, the first 2 intercepts that I mentioned, we identified as very important. And the Intercept 0 is when mobile crisis teams respond to an incident rather than the police or the fire department, or what Detective Taylor has been leading, one of her projects, is a co-response when both behavioral health and police would respond to an incident. Likewise, what both the police department and fire department would like to be able to achieve is emergency department diversion. All of the key stakeholder providers, public safety and the emergency department, believe that in many times the emergency department is not the appropriate care delivery location for persons with behavioral health crisis. And then likely Intercept 0 focuses on police-friendly crisis services, again, which Detective Taylor leads a crisis intervention team. So that's Intercept 0. And then Intercept 1, which we'll also talk about today, is in the 911 center itself, is dispatcher training, specialized police responses, again, Detective Taylor with the crisis intervention team at the Phoenix Police Department. And then intervening with super utilizers, which we are doing with our crisis response network partner. Next slide, please. So each of the 5 sequential intercept levels has best practices associated with it. And there are 2 important special best practices that we are focusing on. One is the cross-systems collaboration and coordination of initiatives, which is exactly what our multi-sector research has been looking at. And then secondly is access to treatment for mental and substance use disorders. And again, that is a multi-sector challenge. And the real opportunity is how to proactively intervene before a person's condition leads to a crisis response, needing a crisis response. Next slide, please. So you saw that the total calls to the 911 system in Phoenix are over 2 million a year, 2 million calls a year, of which about 9% are the fire department. So on the bottom row, the total calls to the fire department annually are about 215,000 calls per year. What's interesting is the bulk of those calls are for EMS. So 186,000 of those calls, about 85% of all the calls to the fire department are EMS calls. And very few of them are for fires. So about 10%, 21,000 are for call-outs for fires. The bulk are for EMS. And the bulk of those EMS calls are for behavioral health purposes. So next slide, please. So our study with the fire department involved emergency department diversion. And that's where one of the conflicting financing mechanisms pops up, because the fire department is only allowed to transport persons to the ED. And and that's because of the payment mechanisms by the state Medicaid program. Although the ED and the fire department, the EMS experts, both know that that may not be the best location to transport a person, that's the only location they're able to transport the person to. So we worked with the fire department and the crisis response network to develop a mobile application, and especially for use with their high frequency users. And we also worked to coordinate with the fire department and the crisis response network a direct line in order to divert away from the hospitalization alternative, which is all that they have. All of that project involved convening multi-sector stakeholders. And as the project got underway, we had a quality improvement team that would meet either weekly or bi-weekly to review all of the cases that went into this new diversion process that was set up by the fire department and the crisis response network. So we used a PDSA approach, Plan, Do, Study, Act, in terms of improvement science. Next slide, please. So onto the police department. At the police department, the focus was on both Intercept 0 and Intercept 1, which is where Detective Taylor has spent so much time improving the systems in the Phoenix Police Department. And Detective Taylor has had a number of years of expertise in this, but one of her most recent projects was developing a co-location pilot project in the 911 dispatch center, as well as some co-location that she might be talking about that they actually do in the police cars as well. But what the co-location project involves is a behavioral health expert who's actually located in the 911 dispatch center. And that person is, so there was a training that was provided to all the 911 supervisors, and then they worked with their dispatch teams to rely on a behavioral health expert who is actually embedded in the 911 dispatch center. And that project has been kicked off, but it's been slowed down a little because of the COVID. But what we will be doing is analyzing data on impact and outputs and so forth and process measures in terms of the effect that this behavioral health co-location pilot project has with the 911 dispatches. And the goal is to optimize diversion through more effective triage. So again, the police department is the first to say that unless there truly is a risk to self or others, that other responders are more effective in dealing with behavioral health disorders or behavioral health crisis. Next slide, please. So our pilot study involves specifically the 911 dispatch. And as you saw previously, there are over 2 million calls annually to 911, and a number of those are behavioral health related. And the police department, from the top leadership and from Detective Taylor, has a commitment to multi-sector integration in order to better serve behavioral health crises. And the crisis response network is the crisis response line for all of Arizona. And of course, the majority of the activity is here in the Phoenix metropolitan area. But Detective Taylor has some analysis that of those 2 million calls that go to the 911 system, in the most recent year, only about 2,700 of them involve direct contacts to the crisis response network. So again, it's known that the calls involving behavioral health are a substantial portion of the 2 million calls, but they involve the CRN very, very small, less than 3,000 times. So we conducted a focus group analysis for the police department leadership and for Detective Taylor to identify the factors that are associated with the low 911 use of the CRN system, as well as focus groups with the frontline officers in terms of their use of the CRM services. Next slide, please. So the focus of today's discussion is this, and the focus is that we have been working with two nationally outstanding public service departments in Phoenix, the Phoenix Fire Department and the Phoenix Police Department. And both organizations have outstanding leaders and have a real commitment to improving the responses for the multi-sector behavioral health. However, the outcomes of these projects are tremendously different. Although it's in the same city, with the same stakeholders, with the same mayor, with the same city council, and working with the same crisis response network and so forth, the intervention with the Phoenix Fire Department was terminated prematurely, whereas the intervention with the Phoenix Police Department is thriving. And we wanted to use that as a study in terms of the factors that lead to success or the termination of projects. And we put it in the context of improvement science in terms of failure modes analysis in comparison to positive deviance. So here are some factors that, as we've been talking with our stakeholders and interviewing them, and this is coming from our stakeholders, and we're classifying and categorizing all the input that we are receiving from them. That with the fire department, there was occasional and intermittent attendance at the meetings, and it was inconsistent attendance by the same person. So there are a rotation of persons who attended the QI meetings and the organizing meetings and so forth. Of course, this is an exogenous factor, but the fire department had a turnover of some key champions during the course of the project. With respect to the fire department's work with community stakeholders, both the fire department and the stakeholders indicated that there was a history of stalled initiatives. And with respect to the frontline engagement, as I mentioned with the fire department, with the leadership, there was also inconsistent engagement at the frontline level, as well as some resistance to looking at different ways or new ways of doing things. And then when there were follow-up consensus by the Quality Improvement Committee and others, the follow-through from the fire department was sporadic rather than consistent. Now that's in contrast to the police department, where multiple leaders attend all the meetings. It's featured by consistent champions. And the police department has a history of multiple successful community partnerships working on innovative projects. And the frontline engagement, for example, at both the frontline officer level as well as the 911 system, the 911 staff were very welcoming, engaged, and interested in developing new initiatives. And the follow-through has always been consistent. So next slide, please. So as I mentioned previously, the police department, the components and the factors of the multi-sector success in the police department could be characterized by positive deviance, whereas the factors leading to the outcomes of the multi-sector intervention with the fire department could be characterized by failure modes. That's a technical term, by the way, not a critical term. And so we identified 4 dimensions. Next slide, please. That were heuristic in terms of understanding the cause and effect of the failure modes. So the 4 dimensions are the financing mechanisms, the leadership, the organizational culture, and then the organizational processes within the fire department. Next slide. And we developed a cause and effect diagram. So if you look at the far right in that orange box, it says Phoenix Fire Department pilot project termination. So the fire department notified us a couple months ago, and they were very, very apologetic, but they had indicated that they were unable to continue with this project. And so we worked with the fire department leadership and with others to, if they would be willing to help us understand the exigencies and the trajectory that led to that decision. And so, as you saw in the previous slide, so far we've been able to identify 4 dimensions. So the financing mechanisms, for example, the Medicaid funding for the ED transport, the leadership where there was turnover of key champions, the culture, the fire department culture is ingrained with zero failure tolerance. It's a shift work culture, and there is a very strong organizational culture in the fire department. And then the third are the processes within the fire department that the fire department identified that there's for historical reasons, it's their perception that they don't get as much city support for initiatives as other departments within the city. There was about an 18-month delay, for example, in getting the MOU finalized with the fire department, whereas with the police department, it took about 30 days, for example. And then there were a number of data sharing hurdles that we never were able to fully overcome. So this is called a cause and effect diagram. And it's really useful in the science of improvement because there are always a multiplicity of causes when a process failure occurs. And so we're using this as a basis to study the comparison and the contrast between successful and unsuccessful multi-sector initiatives. So with that, next slide, please. Okay, so Chris had introduced Detective Taylor earlier, and Detective Taylor is a national leader in crisis intervention training, which is called CIT. And she's a highly respected law enforcement expert, both locally and nationwide. And it's really been our privilege to work with her for over the past 4 years on these multi-sector initiatives. So with that, Sabrina, if I could turn it over to you, please.
Thanks, Bill. Thank you so much. It's been our pleasure to work with you also. Data can be a challenge for a lot of police departments. Anybody who's ever tried to discover police data will understand the frustration. And part of that is the system is built for analyzing crime, specifically violent crime. And what we're looking at here with behavioral health involves no crime. So it's really difficult to sort of dig in and try to get some of the data points that we're looking for. So our partnership has been very helpful to us. And like Bill mentioned, for our particular project, we wanted to look at the 911 system, and particularly because when people are struggling and they want some help and they don't know what to do, 911 is a number that's been heavily publicized, well-funded, and it's generally who people reach out to when they want help and they don't know who to turn to. So the 911 operator or that call taker could be the first person to talk to this person that's struggling in an emergency. And therefore, it's our first chance to sort of catch this and divert it to behavioral health. So we suspected that there are probably times where people called and they just didn't really need any kind of first responder approach, but based on our triage, that's all we really had. And the city of Phoenix has promised its citizens that if you call 911 and you say you need the police, then we'll send you the police. You don't need to have a valid reason. In spite of that, we do know that our dispatchers heavily triage, where they don't send officers on every call that they get, but they do send officers on a significant number. So we gave a little bit of training to our dispatchers, in addition to some of the suicide intervention that they already knew and some of the crisis negotiations that we'd given them over the years. And then this we modeled it sort of after the traditional like officer CIT training, where we are able to bring in someone from the community, and since we were partnering heavily with our crisis line, we brought somebody in from the crisis line to give a in-person presentation, answer questions, and really build up the trust. Because this, while it's pretty common in today's society that multiple agencies work and partner together, it's still a very odd concept for first responders. As you could tell from Bill's discussion of the fire department, police departments and fire departments have a very insular culture. We're not even used to working with each other or other departments in our city, never mind external partners that aren't even in the first responder realm. So a huge part of CIT is introducing these outside partners to our frontline staff, but also building up enough trust with them that they can rely on them to sort of help us out. And especially when you're talking law enforcement and we see, liability and responsibility and what's it going to look like in the headline tomorrow when we refuse to send an officer to this person and we try to transfer them to this other random agency and we don't know their policies and we don't know what they did with them. So after a little bit of training, some trust building, we also had our dispatchers go and do tours of the crisis center. Some crisis line supervisors came over and did tours with us. And we started to see pretty positive interactions between our staff. And then with the help of Bill and ASU, we did some focus groups. We had, at least for a couple of days before the stay-at-home initiatives, had one of their supervisors embedded in our dispatch, and we found that they were able to observe and kind of look at the process and see where we needed to make improvements so that we could increase the number of calls that our 911 call takers were just straight transferring over to the crisis line. So this is very often we get people who call in and they're feeling suicidal. They might be pretty low risk. They don't have access to a means. They don't have a plan, and they just want to talk to somebody. And sometimes they actually will tell the dispatcher that they don't want to talk to the police. They're afraid of the police, but they didn't know who else to call. And so those are perfect handoffs that our call takers can call over to the crisis line. They can introduce the person and they can do the warm handoff. And then our crisis line specialists can talk to the person longer. And if in the course of that conversation more comes out where it does start to sound dangerous and like they might need to the police, they will definitely send it right back over to us or keep the person on the line and use us to dispatch police. But that happens less than 1% of the time. So it's not super common, but our 911 call takers are limited to sort of a 3-second triage or 3-minute triage, and so they don't have the time that the crisis specialists do to really dig into what the problem is. So we had to have that safety net. And then I think that's all I had to add. Bill, thank you.
Thank you very much, Sabrina. And Sabrina's just scratching the surface of the great work that she's been doing with the police department on behavioral health processing. But Chris, back to you for Q&A, please.
Thanks, Bill, and thank you, Sabrina, for the great commentary. So we'll move on into our Q&A section. If anyone has questions, feel free to add those to the Q&A box. And while we wait for a couple questions to come in, I guess I'll start us off with a question for Sabrina. You mentioned that of course this is multi-sector work is difficult, and it's especially difficult when you're dealing with multiple departments that have their own culture and are used to doing their own thing. do you have a sense that there's a shift in the willingness to collaborate across departments, since there's such a strong stakeholder consensus that the current system is poorly aligned? And if so, you know, or if not, what do you think it will take for these programs getting more used to working together and having more trust across those departments?
Yeah, I think things definitely are shifting. I mean, we've been fortunate. The Phoenix metro area started CIT, which is basically just a fancy name for that multi-sector partnership, back in 2001. And so it was pretty rough going in those early years, but it has become more and more refined. And so, you know, I actually, there's the Crisis and Veteran Services Director at Mercy Care, which is our primary behavioral health authority. She and I spend basically every day together. I call her my work wife, and I never thought that my partner would be not only not a law enforcement officer, but not somebody that even works for the same city that I do. And in the last few years, the cities around our county, all of these behavioral health partners, we have all really come together to work on this. You know, our university counterparts, there's just so many people at the table, and everybody is very much interested in the same thing, you know, improving services for those in our community that are struggling, improving support for each other. There's a term that the president of CIT International uses called narrowing the net. You know that you're never going to get law enforcement and first responders out of the business of behavioral health, but you can reduce the amount of times that they're involved and increase the amount of times that people are getting treatment from appropriate services. So, you know, we still have the challenge of data silos and HIPAA, and in the age of privacy concerns, that's a huge hurdle. And then, of course, none of the people that are involved have a plethora of funding. And so systems improvements are great until they start costing money. But we're able to all work together to try to navigate those particular challenges. But I do definitely see improvement, and I see things improving.
Oh, that's great. Thank you for the response. I want to, I have a few follow-up questions, but want to definitely make sure that we're including the audience. So I'll move on to Hannah Stewart. Wants to know, okay, so she's wondering how those with lived experience with behavioral health concerns and crisis service users were engaged as stakeholders in the development of these projects and input utilized in the QI process.
That's an excellent question, Hannah. Sabrina, should I take just a quick shot, and then could you please elaborate?
Yes, please do.
So as I mentioned, we've had just a tremendous group of stakeholders involved in both phases of our Collaborative Research Center for the Behavioral Health Multi-Sector effort and initiative. And from the very beginning, not only did we have tremendous support from the service agencies, such as the Crisis Response Network, Public Safety, and the various sets of providers, we also had several behavioral health advocacy groups that, and from those behavioral health advocacy groups, we had the involvement of behavioral health users. So they were very, very instrumental in the initial phases. And Sabrina, if you could take it from there, please.
Sure. So advocacy groups are definitely a central stakeholder and should be included in most meetings and policy. We work pretty closely with our local chapter of NAMI, National Alliance on Mental Illness, and there's another organization of advocates here called David's Hope, and we work pretty closely with them as well. And I'm in meetings with them monthly, listening to what their concerns are and what their challenges are, and they're very supportive. It's because of their advocating that I have the job that I do, and I have the support from our mayor and city council, and we have, you know, the political support for all these projects, because without them that wouldn't exist and that wouldn't be a focus.
Great response. So our next question is from Nicole. She says, thank you for such an interesting presentation. She'd like to learn more about your evaluation efforts, i.e. methods, findings. Are there publicly available documents that describe how you went about evaluating these projects?
Another good question, Nicole, thank you. There are several sets of outcomes that we have, and we're delighted to send those to you, Nicole. Feel free, my contact info is on the screen, I hope. In any event, so I mentioned phase one. Phase one is where we have assembled about 6 separate databases now, large databases for all the Medicaid beneficiaries in the region. And we have been able to uniquely link all of those with a number of other important databases. We're in process of, we've linked it with the county jail and a homeless database, the probation in the court system and so forth. And we're now linking with the police department. But in any event, what we found, and that's, to our knowledge, that's the first time that multi-sector linking has been done on such a comprehensive basis that's going outside of the healthcare delivery system. And so, of course, that also includes all of the healthcare services and hospitalizations and so forth, healthcare utilization. So we have overlapping Venn diagrams of the incidence and the fragmentation of those separate populations, and how the populations decrease and increase depending on what the sector is. So that's number one. With respect to that conceptual model that was presented earlier, we have metrics associated with those 3 levels, and we're in the process of finishing up the analysis on that now. And then thirdly, as Sabrina mentioned, they, like most organizations, they don't have all the information they would like to have. But Sabrina, you might want to touch on what's available and what you've been able to share with us, please.
Sure. Sorry, I had a hard time getting myself off mute there. So fortunately, our behavioral health partners have been able to share data with us that's scrubbed of personal information. So it'll have, for example, the date, time that an officer reached out and asked for, say, a mobile team or information. So I have a lot of my good data comes actually from them that they're able to share with me. I've also been able to run some queries on our computer terminal that the officers use for their calls. So we call it our CAD terminal. And I'm able to look at a few things. I'm able to query some of the remarks and try to identify, how many of the calls for service that were going on are behavioral health related, since we don't have specific coding for that. And then if we look at a very small portion of the city, which I'm doing for a very small pilot that we're running in response to officers co-responding with mobile teams, I can look at each call individually and sort of code it, and we can kind of see how many behavioral health calls this work group is going to, how many times are they corresponding with a mobile team, and we can kind of look at what might be the barriers to that process. I mean, there's been very good studies on mobile teams. There's several out there in the published research. One of the biggest hurdles to mobile teams is response times. And even though we're blessed with it, probably some of the most available mobile teams in the country, we still struggle with that barrier. And so looking at, officer behavior and how we might be able to address that. So that's a little bit of what I've been digging into.
Thank you. And again, we don't have a lot of the info that the police department would like to have and so forth, but we are working on that. And I might mention, just Sabrina mentioned the mobile response teams where they actually go to the scene, and and the ideal outcome is that they take custody. That's not the right word, but they take over the case and then they work with the person, so the police department, the police officers can lead the scene. But in any event, what we have, as we've been doing the interviews with our stakeholders in the social service sectors and mobile transport sectors and so forth, that we've done just some very, very preliminary cost-benefit analysis that, as Sabrina mentioned, a major barrier to using crisis response is the wait time. That both the officers and the EMS experts cannot wait on the scene, so they just dispose of the case either to the emergency department or worst cases to jail. But in any event, if we've been doing just some rough cost benefit calculations, that if there were, the estimates are if there were two more mobile teams available, and those are not inexpensive, but that would reduce the call time down to parameters that would be acceptable to the police officers and the EMS. Chris, back to you.
All right, sorry, my mute button was giving me the fits as well. Great responses. Questions are coming in. Next question is from Lee, and I'll direct this to Sabrina first. Lee wants to know if there was if it was more of an in-house cultural issue, the disparity between the way the police responses were organized compared to that of the fire department, or if there were different standards that led to the fire department being more or less disorganized with follow-ups.
So I'm not an expert on what happened at the fire department. I sort of loosely understand their culture is a little bit different than ours. In some ways it's similar, and in some ways it's pretty different. As far as the dispatch culture and the police culture, it was actually a little bit of a challenge to break into our dispatcher culture. I do remember, well, since 2001, when police have been sort of exploring this idea of working with multiple agencies, we just hadn't been able to bring our dispatchers along with us for some reason. And we had been struggling to do that for years. And right about the time we started looking at this, we had sort of the right people in the right places, the right supervisors that were interested. But I still remember our first meeting with our dispatch supervisor. She's like, "Thanks, but no thanks. I think we're fine." So it took a lot of work to sort of get them interested, build their trust, show them that there was some benefit in this for them. And when they started to realize that they could use mobile teams and our crisis line to help them, when they knew that they had a caller that needed help, but they really didn't want to send an officer or a firefighter, and nothing seemed appropriate, that they could have this resource, they started to get excited. And they really started to sort of buy in, and it's a long, slow ramp up. I mean, person's behaviors don't change overnight, and culture doesn't shift quickly. But we're making progressive strides. And so, we have 911 diverting calls, and now we are trying to explore getting our officers to call mobile teams a little bit more often, trying to work around these response times, because officers very much tend to, I'll own it, we're control freaks. We feel responsible for the outcome of something. It is really hard to hand off something to somebody else. And so we're, again, building up their trust, working on handing that over. And as we look at some of the study results, it's about 50-50 whether officers will just hand it to the mobile team and walk away, or they want to stay, up to 2 hours to just see that final outcome, because it's so hard to relinquish control. So I think, culture definitely does play a part of it here and there. Sorry, I can't elaborate more on the fire department because I just don't know.
Great, back to you, Chris.
Okay. The next question is from Summer. So in this last 9 minutes, I think we'll do 2 more questions, if that's okay with the presenters. Is there a correlation between improving diversion of mental health issues in the hospital, specifically the emergency department, and possibly doing so to prioritize more urgent cases like patients with suspected COVID-19?
Wow, that's a very contemporary question, given the priorities today. Sabrina, are you seeing anything in the police department?
Let's see. I haven't seen any studies, but I haven't really looked about that correlation between emergency room diversions. I have read some anecdotal information that emergency rooms just are not a therapeutic place for somebody in crisis. Generally, they're assigned a room and they're watched, but they don't actually receive treatment, and they wait until they can get placement in a psychiatric facility, either at another floor in that hospital or an urgent psychiatric center or one of our providers in the community. So as law enforcement, we have definitely tried to divert from emergency rooms to one of our providers in the community so that people can start receiving treatment immediately. We have 3 facilities, a few more, 3 facilities that'll take involuntary people and a few more that'll take voluntary people, and they are no wrong doors for law enforcement. So law enforcement can show up with any person over the age of 18, regardless of health conditions, insurance, and so forth. And those facilities will just say yes and begin treating them. They all have COVID-19 protocols. They all have quarantine areas, and they are screening upon entry. And if a person has a fever, they just go to a separate location in the facility for quarantine process, but they're still accepting, and they're not requiring medical clearances or for us to go to emergency rooms. So I'm not sure, does that answer the question?
Yeah, yes, it does. And Summer, you're asking exactly the right question. The whole purpose of both the EMS initiative and the co-location initiatives at the police department are to decrease the transports to the ED or to the jail, because all stakeholders agree, especially EMS and the EDs and the law enforcement, is those are the least effective alternatives for most of these patients. And as to the EMS is overworked, the police are stretched way too thin. Likewise, the EDs and the jails and so forth. So that's the whole point, which is how to divert these persons who are struggling into more appropriate care contexts. So thank you for asking that. And we're working on, we do not have the findings of that yet. It's all preliminary.
Thank you for those responses. So we're going to do one final question. I know there were a few more, but we'll be providing folks with the presenter's information if you want to follow up and continue this conversation offline. The last question is from Luz. What are some personal takeaways you learned during this project about implementation you would suggest to community health members seeking to implement their own community projects?
Sabrina, can I start, and then would you take it away, please?
Sure, yes, please.
Luz, thank you for that question, Luz, because I have spent my entire career in healthcare and public health, and these last 4 years working with the fire department and police department have been the most gratifying projects I've ever worked on. It's been an unbelievable eye-opener for me to see the professionalism and the commitment and the tremendous job at both the fire department and the police department in terms of how they serve the communities, and they truly are on the front line of this multi-sector misalignment with behavioral health disorders. And as I mentioned at the beginning, they're the ones who are the backstop, because in the treatment side of behavioral health, we're the ones who are failing, and then they get left with all the fragmentation and the poor care coordination, and that continues to be perpetuated because of the conflicting financing systems and the fragmentation, both within the service providers as well as within the public safety systems. Sabrina, how do you see that?
Yes, that was fascinating. For me, I guess the things that I take away from this is, when you're dealing with government, it is just very happy to move forward incrementally. So if you're looking at small incremental changes, those will have the greatest chance of success. And then it's a lot about timing. Like I said, we've made efforts since 2001 to sort of penetrate into dispatch, and we've had little trainings here and there, little micro progress, but I have projects that wait in my filing cabinet, and so you work on them a little bit, you hit a roadblock, and you wait. And thanks to this grant and to Bill's support and the right leaders in the right places and the right people and the right champions, I've been able to get quite a few projects out of my file cabinet lately. And it's made for some busy times, but I know it won't last, and then they'll sit and we'll go forward again. So I think patience is a virtue when you're talking about government policy change.
Yeah. Well, Les, I would say thank you for that, Sabrina. If you're working in this space, reach out to the fire department and the police department. It's just tremendous how open and welcoming they are, because again, they're on the front line. They understand this multi-sector fragmentation, much better than we do, I think, number one. And secondly, they really are a tremendous focus for understanding multi-sector approaches to improve equity and to improve population well-being. Thank you, Chris.
And thank you, William and Sabrina, for their great work and for this presentation as well. I think your project really exemplifies why multi-sector research is so important, but also so difficult. There's so many wins and lessons in your experience, and I hope that others were able to learn from your experience as well. We'll be back with our next webinar, April 15th, Optimizing Governmental Health and Social Spending Interactions. But in the meantime, we will be uploading this webinar to our website, systemsforaction.org. So as we are socially distanced and hopefully healthy, please use some of that time to look at some of our previous webinars and get to know some of our other, some of the other work from our grantees. Thank you for joining us, and we'll see you April 15th.
Thanks.